Dr. Excellent. I got Dr. Minelli. Am I pronouncing that correctly?
Yes, you are.
Good, 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 good. All right. Um, so Umberto, if you'll do me a favor then at the end, if you can, once everything is gathered up, if you can send that recording to me, email that to me, I'd appreciate it. I like to have a recording of all my lectures that I do. And I think at some point, maybe near the end, as we finish off, I'd like to have somebody, maybe Umberto or Selena, can get a screenshot of all of us, and I can have that as a souvenir. So okay, well, I guess we're sort of ready to get started. So we gotta get the energy up in this Zoom room. And so what I want everybody to do is we're gonna stand up. Everybody stand up. Get up off your bed. We're gonna make a little noise to get started with. Come on, join in everybody. Join in everybody. Because the most perfect way to start any kind of UCLA meeting is with a UCLA 8 clap. All right. So I'm going to lead it. And I want you guys to just yell it out. I want you to bother your neighbors. I want you to bother your family. I want you to bother your roommates. And we'll go ahead and let's get it ready. You ready? Come on, everybody. Let's get ready for a clap. And 4, 5, 6, 7, 8. UCLA. UCLA. Fight, fight, fight. That's some great Bruin mojo. Great, great, great. All right. So I'm going to go ahead and get started with the share screen. So first of all, I'm hoping everybody can hear me really well. I have this new microphone. Hopefully I come through loud and clear. And we're going to go ahead and get started here.
Before we begin, I just want to point out that Destiny said in the chat that you were making her day.
Oh, great. Glad to hear it. Glad to hear. Okay. A little fluid to get us started. All right. Okay, young doctors, the tale of this presentation today is I have a lot of stuff to cover. It's about 55 minutes, so bear with me. Hope you don't get too hungry. I have sushi waiting for me when I'm done with all this. That's going to be my reward. Hopefully you guys will have equally as good a reward. Anatomy of a toothache and other things that you never knew about your mouth, a biologist's perspective, presented to the great PreDental Society at UCLA. Who am I? Well, I have two professional names. I go by Morris A. Budak, DDS, or Dr. Mo Budak. I was born and raised in San Francisco, went to Lowell High School. I graduated there in 1965. So I'm an older gentleman, or as my doctor recently said, you're a wise gentleman. I went to Cal, graduated in 1970 with an AB in biological sciences. After that, of course, down to UCLA School of Dentistry, graduated in 1974. I'm married, lived and raised my children in Palo Alto. I have two kids, Alex and Alana. I practiced restorative and aesthetic dentistry in Sunnyvale, down the street from me, the head of Silicon Valley, starting in 1974. I retired in January 2018. I had a wonderful, wonderful 44-year reign doing clinical dentistry. I really, really enjoyed it. I loved dentistry 90% of the time. I'm a candidate lecturer at UCLA School of Dentistry, and I'm currently a co-director of the UCLA School of Dentistry Apollonian Society. So what are my connections with UCLA? Well, first of all, the Apollonian Society. This is my Apollonian family right here. We've got Dr. Ron Mito. He's one of the deans at UCLA. He's one of the co-directors with me. The other co-director is Dr. Michelle Okamoto. She's in charge. So Dr. Mito's in charge of Southern California alumni. I'm Dr. Michelle Okamoto is in charge of the young alumni, and I'm in charge of a new program we have up here in Northern California. We're actually starting a whole network up here, and these other people are administrative and hand-holding people. We couldn't do anything without them. Of course, our dean, Dean Paul Kresbach, brilliant man, came to us from Michigan. He's a periodontist, a dean, a lecturer, a researcher, a man of all trades. Here we are enjoying some Jim Boy's tacos down in Anaheim a couple of years ago at the CDA. And here's we are together at the CDA up in San Francisco, my hometown. And the other connection, of course, would be my son, Alex Budak, who was the founder of the Den back in when he first started. And in 2017, he received the recent Graduate Achievement Award. Here he is at age 4. I tried to get him to go to Cal. I talked about him going to Cal. He steadfastly refused because he's always been his own man, and he wanted to go to UCLA. Well, not so bad because I went to UCLA too. So when he was age 4, we took a trip to UCLA. When he was 8, we took a trip to UCLA. And then when he actually matriculated at UCLA, the whole family really, really enjoyed the entire experience. Parents' weekend, going to football games together. We're very proud of him. Here's the school. I hope you've all been there to visit. If you haven't, you should. It's a wonderful, wonderful place. And here I am 2 years ago at what's called the white coat ceremony. If you don't know what a white coat ceremony, all these people who are here are the newbies. They are the new D1 dental students coming into school. They haven't even attended classes yet, and all their families will fill in here. And it's a ritual event where these young people, like yourselves, are actually given their white coat with their names embroidered on them. It's symbolic and it's ritual, and it represents that point in time where you move from just being a regular old person to being a doctor and are addressed as such. So the great thing about tonight's presentation is you don't have to take any notes. There's no quizzes, no exams, no papers, no projects. Just sit back, relax, listen, enjoy learning for learning's sake. So let's jump in and get started. The human tooth. One of these is a tooth and the other's a lemon. Bruins can tell the difference. And now for the lecture portion of this presentation. Remember, and this goes for all things in life, I learned this from one of my mentors, Dr. Bill Dickerson, you don't know what you don't know, all right? So when you're presented with new ideas, think about them, be ready to accept the new paradigm. That's the only way this science grows. And don't be so haughty or arrogant that you know everything. You know, after I graduated from dental school in 1974, I said, I'm ready to hit the streets, man. I am a dentist. I know everything. And, you know, within the first couple of months, I realized I don't know jack. I mean, you know, it took me 10 years before I really understood dentistry. I did a lot of dentistry. I did good dentistry, but to really get the feel, it takes a while. Remember, you don't know what you don't know. What are we as dentists? A dentist is a doctor, an engineer, an artist, a nutritionist, a therapist, an investigator, a scientist, a teacher, a leader, a business person, an entrepreneur, a researcher. Many, many things define the role for us as dentists. That's what makes dentistry, what makes being a dentist such a wonderful, wonderful job. It's the best job in the world as far as I'm concerned. The mouth is our portal to the world, known by us as the oral cavity. And I wish for you that all your patients would look like this. Man, you could stand on this guy's tongue and do all the dentistry that you need for him. The oral cavity has fittingly been identified as the organ system where it all begins. Okay, so the oral cavity. We start by identifying that the oral cavity resides in the lower mid-face, whose bony skeletal structures include the maxilla, the upper jaw, in blue, the mandible, lower jaw, in yellow. That's the temporomandibular joint right there. Then each jaw houses 16 teeth in the adult. These are known as the permanent or secondary dentition. We just call them the permanent teeth because children have 10 teeth in each jaw, a total of 20. We have a total of 32. Kids have a total of 10. That's known as the primary dentition or primary teeth. And of course, I mentioned to you the temporomandibular joint, which is a very complex joint that's guided in multi-dimensions. And it guides all of our chewing, our talking, and how we move our face. And truthfully, it's a trouble spot for many people. Let's take a look at some of the structures in the mouth. We first start with the soft tissues. We, of course, got the lips. We've got the gingiva, the attached gingiva. Here, that's the gums, all right? The fancy term for gums is gingiva. Back when I was a student, 1971, I actually wrote a song, Gingiva, Gingiva, G-I-N-G-I-V-A. I play it with my ukulele. I won't do that today, maybe for another time. It's a great song. I get everybody just singing away in it. We've got the floor of the mouth, and this image, we've got the tongue raised up, and that's the floor of the mouth right there. The buccal mucosa, this is misidentified. The buccal mucosa is the lining, the skin inside the cheek. Anytime you heard the term mucosa, that means skin on the inside of our body. We have nasal mucosa, intestinal mucosa, oral mucosa, and that skin which aligns the inside of the cheek is called the buccal mucosa, inner cheek lining. We, of course, have the tongue. This one's pulled up to view the ventral or the underlying surface right there. We've got the buccolingual vestibule. The vestibule is that little groove that comes down here between your teeth and the lips, right? And that's the maxillary vestibule, the mandibular vestibule. Palate is divided into the hard palate and the soft palate. The hard palate, you can feel it with your tongue right now. That's where the skin in your hard palate lays up against the palatal bone. And the more posterior you go, you don't feel bone anymore, and that soft tissue right there, which is now called the soft palate. And from that hangs the uvula, the little hangy down, we call it the punching bag. We have our tonsils, and the tonsillar pillars. And right back here, this is called the oropharynx. The pharynx is basically the throat, all right? And you've got the oropharynx, as identified here, is the most posterior or dorsal part of the oral cavity, right? And just like in behind the nose, you have the nasopharynx, the very most dorsal or posterior part of the nasal cavity is the nasopharynx, and the pharynx eventually goes down and splits into other structures. Here's our gingiva again, gingiva, Gingiva. Here's our attached gingiva, our unattached gingiva up here. We've got the papillae. These are these little triangles right here are called papillae or papilla. Interdental gingiva, that's an old English term. And then at the floor of the mouth, again, I'm showing you some of my favorite spots. This is called a frenum or a frenula, all right? That frenum is a connective tissue membrane that attaches one surface within the oral cavity to another. So in this instance, the tongue is pulled up, and this frenum is called the lingual frenum, attaches the ventral or underside of the tongue to the floor of the mouth, all right? If we are born or have a very tight lingual frenum, which does not allow free movement of the tongue, that's called tongue-tied. You've probably heard that term. You feel tongue-tied, you talk tongue-tied. Well, tongue tie is actually can become a very serious condition. And what I mean by that is adults who have tongue tie have a serious speech defect. They can't pronounce the letter L or some other words either, which requires the tip of the tongue going to the top of the roof of the mouth. L, la, 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 la. And so when they say a sentence like Lulu loves lollipops, it'll come out Lulu loves lollipops because they don't have tongue mobility. It's also very problematic for the very young child, for the infant, for the newborn. If they're tongue-tied, they can't latch onto breast. They can't nurse themselves well. And there are some specialists that go ahead and actually do a lingual frenectomy. It's a surgical procedure where you actually cut the frenum to free up the tongue and loosen everything so that infant can then begin to suckle on the breast. For the adult, a tight lingual frenum does not allow the tongue to rest in this normal position and create orthodontic problems, upper jaw problems, facial growth problems, and ultimately airway problems, breathing, obstructive sleep apnea, sleep breathing disorders. We have salivary glands and salivary ducts. All right, the glands are where the saliva is produced, and the ducts are the little straw tubes that spill the saliva into our mouths. So we have a total of 6 major salivary glands. We see, 3 of them on one side here, and 3 will be on the other side. These are 3 on the right side of the face. This is the parotid gland. That's the largest one. That spits the most spit, located just in front of the ear. When this becomes inflamed, that's the mumps, parotitis. We've got the sublingual gland right underneath the tongue. And if you lift up your tongue and you swallow, you can actually squirt some with the spit that comes out of there. And then the submandibular gland, that's the salivary gland that lays below the mandible, below the lower border of the mandible. Now that you know what a mandible is, all right? And it also secretes saliva into the oral cavity. There's a couple of interesting spots that I want you to understand, or I'm going to give you the orientation. We're looking at the patient's lower left-hand side, last molar and the molar just in front of it, all right? Here's the buccal mucosa on the lower left-hand side, tonsillar pillar, and you can imagine there's probably a big old tongue over here somewhere, all right? There is a little, and you can feel this with your tongue, there's a pear-shaped pad in back of your lower molar that's kind of hard. That's called the retromolar pad. It means behind the pad that exists behind the molar. There's also this tissue right here, which is called the operculum. Now, this operculum can become really problematic because if you jam food down in there, get an infection, stick some popcorn down there, it becomes inflamed and swollen and pus starts coming out, or a wisdom tooth is trying to erupt and causes an inflammation of the operculum, you develop operculitis. This is a highly inflamed operculum right here. And this is a very painful condition. You get fevers, pus, swelling, bad breath, really disgusting. So the way we treat this is we surgically excise it and do what's called an operculectomy. We take away the operculum. Anytime you see itis, that means inflammation of the operculum, operculitis, inflammation of anything, gingivitis, inflammation of the gingiva or a gum disease, all right? Oftentimes, this is an operculitis can occur as a result of a wisdom tooth attempting to erupt. And I will venture to guess that out of the number of people that are watching this right now, some of you may have actually had operculitis. I'll bet a lot of you will have had to have your wisdom teeth removed. If not now, then later. This is an interesting one. All right, let me give the orientation again. We're looking down into the left side of the person's jaw. This is an upper left teeth, lower left teeth. There's your tongue. There's your buccal mucosa. There's the tonsillar pillar. And there's this little groove right over here. This is called the pterygomandibular raphe. You've now learned a really fancy word, pterygomandibular raphe. What is the significance of this X? That X, young doctors, that's where you're going to take your syringe, and that's where you're going to inject your local anesthetic, finding the jaw nerve way down inside there someplace to get a lower teeth numb when it's time and ready for you to do some dentistry on this patient, on the lower jaw. All right, now I'm going to talk about the gastrointestinal system because the oral cavity represents the first of the anatomical structures of the digestive tract, otherwise known as the alimentary canal or alimentary tract. It's basically just a long tube or donut that starts from the mouth, from the pie hole, and ends in the butthole, all right? And all these structures along the way is all internal to the body, but it's really outside of the body, right? This is what's happening inside here is not inside the body. It's actually happening away from the body. Pie hole to butthole. I love that term. All right. So the gastrointestinal system, there are 5 stages of how we process food. The first stage is the cephalic stage. This is what our brain is making us do, all right? You're driving by KFC, and you smell that delicious chicken. Worst stuff for you. Anyway, you smell the delicious chicken. Now it's a lovely smell, and now you start to salivate. That's the cephalic or the brain phase of digestion. We then move into ingestion, where we actually take in the nutrients. And the mouth is largely responsible for taking in the nutrients and starting to break them down. Then there's the actual digestion. We're using physical and chemical means to break down the complex organic molecules into smaller usable parts. So when we ingest, our teeth grind everything up. The enzymes in our digestive system begin to break it down chemically until it can go into absorption. This happens largely in the small intestine, where these molecules, organic molecules of food, are so small that they're pulled and digested into the cells of the digestive tract, and they cross that barrier from the internal wall of the small intestine into the bloodstream. That's how we get glucose, our sugar of life, into our bodies. And of course, excretion. That's the pie hole to butthole. All right, how horrible it would be if we never got to excrete. So in this cephalic phase, I'm going to review this again. Sensory inputs, sight, smell, feel of food, triggers a release of chemicals in the stomach. An appetite-stimulating protein peptide called ghrelin is found mostly in the stomach and is capable of brain signal communication. Hence, our brain will stimulate saliva flow when we are hungry. So there's this cross communication, what we call the gut-brain complex, brain-gut complex. They're communicating back and forth with many protein peptides. Ghrelin would be one of them. Interestingly, some companies are putting ghrelin in their processed foods. So you're constantly, as you're eating that food, your appetite is constantly being stimulated. So you eat more food, you buy more food, you eat more food. It's really evil stuff. Anyhow, here's a quote. Mit Essen kommt das Appetit. That's German. Is with eating comes the appetite. And this was quoted to me by Adele Binder, my maternal grandmother. I always thought kind of old wives' tale, but really she was speaking truth to science. She was really talking about Garland. All right, let's talk about ingestion, the oral cavity. The food enters the gastrointestinal tract through the lips and into the mouth, where it becomes physically and mechanically broken down. Let's stop and take a look here at this beautiful smile. All right, I want to identify to you the lips and this border, the outside border, the Cupid's bow, that's called the vermilion border. All right, and let's take a look at these central incisors. A thing of beauty for an aesthetic dentist like myself. What characteristics do we see about that? It's full of texture and there's grooves. So as the light hits that tooth, it's spraying light in different directions, all right? A really lousy cosmetic dentist, or what they think is a cosmetic dentist, is going to build this structure real flat because that's a really easy thing to do. That becomes a mirror and it just sprays light straight back to the viewer and it looks phony. It looks like chiclets. A good cosmetic aesthetic dentist like myself is going to take into consideration what the form and texture of the enamel of the restorative material that we use is going to look like, so that as the light comes in, it's reflecting and reflecting and bouncing light off in different directions to give it a natural looking appearance. So we have the physical breakdown within the mouth. And of course, the two main structures are the teeth and the tongue. Our teeth are going to chew and grind everything up. And the tongue is the little papillae, which contain your taste buds, right? That's how you taste things so deliciously. But the roughness of this also breaks down food product and beginning that digestive phase. Let's take a look at some of the teeth here right now. This image is by Frank Netter. He's probably the most famous anatomical illustrator in the world. And this is right out of his textbook. I read that textbook. I used that textbook for my gross anatomy classes when I was in dental school. And we're going to talk about the various kinds of teeth that exist. So we have 4 different types of teeth. We have the incisors. We have 8 of them, right? We only have 1/2 of the mouth here, so double that. Central incisors, lateral incisors, so we'll have 8 of them. They're used for cutting the food. Then we have the canines. We have 4 of them. They're used for piercing and tearing food. Then we have the premolars. We have 8 of those. They're used for piercing and tearing food. All right, so they're kind of halfway between a canine and a molar, because the molars crush and grind the food. All right, so we've got central incisor, lateral incisor, canine or cuspid, first premolar, second premolar, first molar, the 6-year-old molar, second molar, the 12-year-old molar, and third molar, the 18-year-old molar. That's your wisdom tooth. Those can sometimes be the bad guys. Like I said, I'll bet there's a bunch of you that have had or will be having your wisdom teeth removed. Not enough room in your jaw. When we grind up our food using our tongue and our teeth and other structures, it forms a food bolus. Here we can take a look at this depiction of teeth. I've already described that for you, but tooth number 1, tooth number 16, tooth number 17, tooth number 32, those are the wisdom teeth, and you probably will be missing them. All right, let's not forget the rugae. All right, take your tongue, put them right behind your central incisors. You're going to feel these grooves right here. Those are called rugae. All right, what a great crossword puzzle word for you. All right, and the rugae are like the fingerprints of the oral cavity. They're sturdy pieces of connective tissue which also break down food to form the bolus. And these are actually readily, no 2 people have the same rugae in their mouth, and forensic odontologists, forensic dentists can sometimes identify a patient by the shape and size and location of the rugae. We talk about the chemical digestion, and our digestive system uses enzymes to break up food. In the mouth, our salivary glands produce saliva, and the saliva contains an enzyme called amylase. Amylase acts on starch, the carbohydrates that come inside the mouth, and break them into maltose. Further down in the digestive tract, the maltose is broken up into 2 molecules of glucose, and the glucose is then absorbed through our small intestine. The bolus is the resulting ball of food in the mouth made by the action of the teeth, tongue, saliva, and the rugae. Don't forget our rugae here. All right. So down here, Dr. Azim Laka, he's one of my mentors, and his famous quotes to me are, "The dentist is the custodian of the healthy mouth." That is to say, when we find an unhealthy mouth, it is our charge to make it healthy and to be the custodian of that healthy mouth by doing the proper things, by educating our patients, and by concentrating on preventive care for them. That's what you guys are doing when you're going out and doing oral hygiene development, oral hygiene instruction to your patients when you're out doing a community service. The progression to oral disease is common, right? Most people have got some form of oral disease. The progression to oral disease is preventable. How is it preventable? Good diet, good nutrition, wearing sports guards, avoiding trauma, avoiding cancer, doing all the right brushing and flossing. Most of the diseases of the mouth are preventable. And the progression to oral disease is associated with systemic disease. There's a cross connection between disease in the mouth and disease in our bodies, which I want to review with you and then cite you very specific examples. So this is kind of funny, but really, in a way, it's kind of the truth. And I can tell you what happened to me all the time in my practice. We had some subset of our patients that simply wouldn't floss. Well-meaning people, they wouldn't floss. I don't judge them. But, a couple, 3 days before their hygiene appointment, they knew they wanted to get cut up and they would floss like crazy. Well, what happens when you floss really bad gums, it causes something called a rebound effect. And the gums actually become worse and puffy and swollen. By the time they come in to see me, these patients look worse than had I seen them had they not been flossing. And I look in their mouth and I go, oh, I can see that you've been flossing, knowing full well exactly what they were trying to pull off. You can't get it by us, though, and you will learn that when you become a clinical dentist. All right, so we're going to now talk about the oral systemic connection, and we are ready to say floss or die. Dentists have recognized this for a long time. Our medical colleagues are beginning to recognize that the inflammation that resides in the oral cavity becomes translated to many parts of the body through the bloodstream and lymphatics, all right, to create inflammatory response in other parts of the body. And this can result in cardiac disease, very clear communication, pulmonary disease, COPD, strokes, gastrointestinal problems, ulcers. H. pylori is a bacteria live inside the mouth. We swallow that, and that can cause ulcers. Colon cancer, renal disease, glomerulonephritis, a kidney disease, really serious. These are the glomeruli are the cells of the kidney, and nephritis means inflammation of the kidney, pretty serious disease. Preterm babies, we know this for sure. Preeclampsia, osteoporosis, that's soft bones. Chronic fatigue, a very difficult condition to treat. Diabetes, definite cross connection between diabetes, blood sugars, and oral inflammation. Oral and pharyngeal cancer, HPV, human papillomavirus. Low fertility in men, erectile dysfunction, brain abscesses, Alzheimer's disease. Yes, Alzheimer's disease can be derived from inflammation from the mouth, and rheumatoid arthritis and COVID-19 comorbidities. Some studies are clearly showing that a lot of people that the most severest cases of COVID-19 were in individuals that had comorbidities, right? We know about lung problems. We know about obesity. What we're not talking about is people with really poor oral hygiene, and they already have lots of periodontal and gum disease problems. And a lot of this stuff is happening in the mouth. So COVID-19 comorbidity is one of the problems associated with poor oral health. So let's now talk about the tooth. The tooth is composed of three things: water, organic material, and inorganic material, mostly calcium phosphate. For you chemistry wonks out there, Ca3PO42. I actually drew this image a long time ago, and so I like to use it. This is a cross-section of a tooth, the crown of the tooth as it lives above the gum line, and the roots of the teeth as they are installed into the jawbone. Outer layer of tooth structure is enamel, very dense, very hard, all inorganic. Next layer of tooth structure is called the dentin, half organic, half inorganic, a little softer. Next layer, the dental pulp. Many people call this a dental nerve. That's not right. Never use the term dental nerve anymore. You are young doctors. It's called the dental pulp. Why? Yes, there are nerves that run through there, but there's also blood vessels, connective tissue, stem cells, a whole soupy mass of organic stuff. It's a very complex organelle inside there. The outer layer of the root is called cementum. The junction between the cementum and the enamel is called the cemento-enamel junction. The junction between dentin and enamel is called the dento-enamel junction. Remember that DEJ. We'll talk about that later on, the DEJ, the root and the root apex. Here's what I want you to remember, all right? The apex is at the end of the root tip, all right? And at the end of the root tip is a very tiny little hole in the roots of our teeth. That's called the periapical foramen, the hole at the end of the apex, around the end of the periapical foramen. In anatomy, anytime you have a foramen or foramina, it actually means window, Latin for window. It means a hole, all right? Well, it's through this periapical foramen where the blood supply, nerve supply, connective tissue, all the organic goop enters and leaves the body. Remember this, root apex or periapical foramen. We'll be coming back to that later on. All right, the tooth. Again, another review. We've got the enamel. We've got the cementum, the outer covering of the root. We've got the dental pulp. We've got dentin. And within the dentin are a fine little straw, little tubes called the dentinal tubules. All right, and they are filled with fluid, which is constantly changing from the pulp to the DEJ, the dentino-enamel junction. Let's take a closer look at it right here, and look at this micrograph that I found, a section of tooth. Is just, to me, this is absolutely beautiful, especially as we can match up my drawing, my artistry with the real world. So enamel is made up of calcium phosphate arranged in a dense crystalline structure, and that's called the hydroxyapatite crystal. And they're in the form of rods, enamel rods. Remember, hydroxyapatite crystal for you chem walks, we'll be talking about that in just a moment. Here we see the enamel. We see the dentin. We can see the dentinal tubules, and there's the pulp. Can't really see the rods right there, but the important thing is this hydroxyapatite crystal aligns itself into the enamel rods, and they will demineralize at a pH of 5.5. Why is this important? Okay, you chemistry majors. 5 point, the 7 is neutral. 5.5 is slightly acidic. Our enamel will begin to break down, demineralize, loses some of the calcium and phosphates out of the enamel structure at a pH of only 5.5. Right? You'll understand this better on the next few slides. Here we go, close up of enamel rods. Just a gorgeous micrograph right here. And here's our DEJ. Up close and personal. Another view, enamel rods, slightly different magnification, different kind of microscope. And here, the enamel has been sectioned or cut. This is a occlusal bevel. It's been cut like we do with our drills, with our hand pieces when we're preparing the teeth, all right? And we purposely want to flatten out these rods, drive up their energy, and we actually can bond dental materials onto the surfaces and create a filling or a crown. If you can, when you can, when the campus is open, take a walk up to the School of Dentistry, go into the lobby, and you'll see this beautiful relief sculpture in the lobby of the dental school, and it actually represents enamel rods in the lobby there. And I remember when I first started dental school, I didn't think very much about this sculpture, and then as I began to learn my dentistry, I would spend a bunch of time just looking at these rods and imagining what this looked like in my very own teeth under the microscope. It's really a beautiful sculpture. Here we go. The crystal enamel surface, Ca3PO4 That's your calcium phosphate. However, the hydroxyapatite crystal lattice looks more like that. Here's our Ca3PO4s, 2s, but hanging on to them are hydroxyl ions. All right, remember that, because that's why this crystal lattice is called the hydroxyapatite crystal. Calcium phosphate with hydroxyls hanging onto it. That's what gives enamel its strength. But check this out now. All right, we've got our hydroxyapatite crystal as a chemical formula for it, hydroxyapatite. What happens when we take that enamel and we bathe it in fluoride? All right, we all know that fluoride makes teeth stronger. Why? How? I'll show you. So if we bathe the teeth in fluoride, like brushing with fluoride toothpaste, or having a fluoride treatment done, or drinking fluoride in the water supply, this fluoride ion supplants the hydroxy ion by ion exchange reaction. It cleaves and changes the hydroxyapatite crystal into a fluorapatite crystal. What's the significance of that? Fluorapatite begins to demineralize at a pH of 4.5, not 5.5. That's why fluoride makes teeth stronger. All right, let's take a look at our dentin. We already know about the tubules. All right, we got the rods of the enamel. We have our DEJ, dentin-enamel junction. We have our tubules running from the pulp up to the DEJ. And here we can see a beautiful replication of it. Here's our dental pulp. Here's those tubules. Boom, boom, boom. They're microscopic. There's millions and millions of them until they come up into the to the enamel right there. Let's take a look at our root right now. We have the pulp material inside the root is called the pulp canal. All right. And the outer layer of tooth structure, of root structure, we already know is called cementum. But let's take a look right here. Someone did a thin section of this, denatured it, and did a staining on it. This is our root dentin. There's our cementum. Well, it's gone now, probably got denatured. But they stained for collagen. These are collagen fibrils that run throughout the pulp space. The nerve and the blood supply and all that, they're gone. We're just looking at collagen right now. But take a look right down there at the end of the root tip where it narrows down. That's your periapical foramen. And remember, that's where all the pulp contents enter and leave the human jaw. Let's not forget about the periodontal ligament. The periodontal ligament is a ligament. It's actually a series of ligaments that line the root of the tooth in the jaw bony socket, what's known as the alveolar bone, the jaw bony socket. And it's like a liner. It's like a gasket, right? It provides a little relief and moves, allows the tooth to move a little bit. This will become more important to you a little bit later on. So how does a cavity form? Dental caries is the medical term for a cavity. What is the pathogenesis toward pain and infection? That's what this lecture is all about. Well, it all starts with bacterial microbes, most specifically strep mutans. That's the bad guy. Normal part of the oral environment. We're supposed to have strep mutans in our mouth. We've got 350, maybe 400 different forms of flora and fauna inside the mouth. They just need to be there in a balanced state. And also lactobacilli, some lactobacilli will be bad guys as well. And their byproduct is acid formation. That's what decreases the pH and begins the demineralization of the enamel. So here we go, all you biochem and microbiology wonks. In S. mutans, incorporated sugars are processed via the Embden-Meyerhof pathway and metabolic degradation. In the Embden-Meyerhof pathway, phosphorylated glucose is metabolized to fructose 6-phosphate, from which acids are ultimately produced. In the dental plaque, strep mutans produces primarily lactic acid and causes acid accumulation. When the pH is below 5.5, demineralization of the tooth surface occurs and causes tooth decay. That, young doctors, is the whole story right here. If you memorize this or remember this for the rest of your lives, you'll understand dentistry. I'm just kidding. You don't have to memorize any of that. Okay, the substrate that goes to the mouth is any fermentable carbohydrate, from sucrose, which is a simple sugar, to the more complex carbohydrates. What I like to call pop rocks to popcorn, right? Pop rocks, very tasty and sweet, probably the worst candy that you can eat, right? Because it's pure sugar that is surrounded with ascorbic acid. So the pH of pop rocks is about 1.5 or 2. Lemon juice is 1.5. It's about a pH of 2. And you crunch on them and get all that delicious sweet flavor. The sugar retains itself onto the tooth surfaces. As it retains there, it's now a perfect substrate for S. mutans to come along, break it down, and cause caries and cause caries. This actually happens pretty rapidly. Whereas we take a look at something like popcorn, which is a complex carbohydrate, much slower to break down, but it still breaks down. And I can tell you the story about a young man, a very obese young man that I had as a patient. And his problem was that he was a glutton. He suffered from a psychiatric disorder called gluttony. He had to eat all the time. He was just this compulsion to eat all the time. And his medical doctor decided he would try to help him control his weight, but understanding that he suffered from gluttony, he said to him, okay, you can eat as much plain popcorn as you want. No salt, no pepper, no butter, no flavoring, just plain popcorn. Well, not understanding that popcorn is a complex carbohydrate that breaks down into sugars and causes caries. I was seeing this guy 6 months later. He's got dental cavities all over the place. We had to do root canals, we had to do crowns. He broke down really fast. Another fun fact about popcorn is popcorn husks. How many of you ever gotten a popcorn husk caught in your gum? Really problematic, huh? Really difficult to get out. Toothpick, floss, try to get it out. Sometimes it's so jammed in there, patient has to present to the dentist to get them out. In my practice, I must have seen 100 patients getting popcorn husks out of there. One patient waited too long. That popcorn husk stayed below the gum line, degraded the gum line, actually penetrated through the periodontal ligament, destroyed the periodontal ligament, destroyed the bone around it. This guy ended up losing his tooth because of a popcorn husk. That was sad. Milk, it's lactose. That breaks down slowly, but still damaging. And so there's some very well-meaning parents who are uneducated. They're ignorant about this, but their little one with a primary dentition, right? Fussy, fussy, fussy when they go to bed. So they take a bottle of milk. They put the bottle in with the child. The child lies down, drinks the milk, nice and calm, falls asleep. That milk now pools in the mouth all night long. S. mutans and lactobacillus begins to act on the lactose sugars that are in there and creates decay. This is a horrible condition. It's called bottle caries syndrome or crib caries syndrome. And your charge, young doctors, when you go out and you're doing your community service and doing oral hygiene instruction, you can maybe even talk to some of the parents that have got young children and talk to them about bottle caries syndrome. Don't put your baby down with a bottle. Or if you want to put it down with a bottle, make it be water, not juice, because juice will do the same thing. Not even diluted juice, diluted apple juice. That'll do the same thing. That's a carbohydrate, just water. The bacteria dental plaque take in the carbohydrate substrate and excrete their poop, which is very acidic, thereby causing demineralization of the tooth enamel by plucking out the calcium and phosphate ions. All right. I've now said this to you 3 times, so it should be firmly embedded in your brains. All right. So when those calcium phosphate ions pluck out, that's what we call demineralization. So there are 5 stages of dental caries development. Stage 1, white spots. Stage 2, decay into the enamel structure only. Stage 3, decay that penetrates from the enamel into the dentin. All right. Stage 4, it balloons through the dentin, penetrates into the pulp. And stage 5, kills the pulp and creates abscess formation. Let me show you an example. All right. So here is stage 1, white spots. No biggie, but we can identify them. So we say, let's put some fluoride on there. Let's put some other sort of, calcium ions on there. Let's give this patient good oral hygiene instruction. Let's instruct the parents that this patient needs to brush and floss. And maybe we can reverse this white spot so it doesn't become stage 2. If we can't, or they won't, it then becomes stage 2. White spots turn brown. That's a cavity there. That's a cavity. That's caries. It's penetrated into the enamel only. All right. Let's take a look at an X-ray. Here's an X-ray of a tooth. You got your dental pulp. You got your root with the cementum. You have your enamel coming out right there, and there's the dentin. Let's take a look right there. You see where the laser pointer is, right above my laser pointer? You see that little notch? That's stage 2 decay. It's penetrated only into the enamel, but it hasn't penetrated into the dentin. No pain associated with that. Until we get to stage 3, dentin caries. All right. Now this bad boy is going on. Penetration occurs through the dentin enamel junction going toward the pulp. That's ugly. That's ugly. You can just see it through the enamel into the dentin. Now, of course, we know the dentin is already softer than enamel, so it's going to really balloon and work its way to the pulp right there. We're going to have mild to moderate pain with stage 3 dental caries. Stage 4, oops, too bad already. Big hole in the tooth, enamel, dentin, caries into pulp. Severe pain. Toothache, that's when they come to you. Stage 5, let's take a look at this X-ray. Enamel, dentin, caries, pulp, pulpal death, toxins, pus, disgusting bacteria expressing themselves out of the periapical foramen and forming an abscess. This dark shadow right here and this shadow right here is a dental abscess. Here's a depiction of it. All right. Decay into the infected pulp, All the contents become pussy and disgusting and break down. Necrotic, the tissue dies. It's called pulpal necrosis and abscess formation, infection at the end of the root tip. That's real pain, severe pain in tooth and jaw. Please, doc, do something. Help me, help me. That's when they come in. They're in acute pain. So why the pain, you may ask? Well, it all has to do with pain and pressure sensory fibers, all right? We're doing a little neurology right now for your neurology wonks. I'm sure you've had some of this in your anatomy courses, all right? So we have two within the mouth. Within the tooth, we deal with primarily two types of sensory fibers. There's the proprioceptive fibers. These are pressure sensing fibers. And then pain fibers. And there's two types of pain fibers. There's the A fibers with both delta and beta, and C fibers. Why they call that, I have no idea, but the neurologists really like to make things complex and confuse us. The proprioceptive fibers, pressure sensing nerve fibers, especially within the periodontal ligament, creates feedback within the chewing system to modulate the strength of biting and chewing function. All right, so you've got your periodontal ligament right here. All right, and we know that it's a bit of a cushion, and the proprioceptive fibers live within the periodontal ligament. So I'm going to give you an example. You go and you buy yourself a really nice sandwich. All right, unbeknownst to you, there's a stone inside that sandwich. You bite down, you start chewing, that stone hits your tooth. All right, something is wrong. We have a pressure gradient that is so high, it's recognized by the stretching of the periodontal ligament. The stretching of the periodontal ligament stimulates the proprioceptive fibers, and an involuntary reaction happens where those sensory fibers communicate with your central nervous system, primarily the spinal tract, sending a signal back to your jaw muscle, jaw opening muscles, to make you open your jaw so you don't bite further into that rock and break your tooth. That's the function of proprioception in the periodontal ligament. If the periodontal ligament forms a cushion of protection, physiological feedback. That's very important in the orthodontic movement of teeth. I'm not going to get into that now. Let's talk about pain fibers and nociception. A nociceptor is a sensory neuron that responds to damaging or potentially damaging stimuli by sending possible threat signals to the spinal cord and the brain. So the two fibers we know about are the A delta fibers that create rapid, sharp sensation, really cold, searing pain that's going through the center of the tooth. And this happens especially with trauma. And then the C fibers create dull, longer lasting pain, chronic pain, pain to heat and inflammation. This is the patient that, they come in, oh, doc, I got a toothache. How long have you had it? Well, about 3 months. I thought it would go away. It's low level pain until it becomes so acute that the A delta fibers begin to fire off and then they need attention. Nociception is the neural reaction to noxious stimuli, and it's a very complex neurohormonal interaction involving inhibition of endogenous opioids. Endogenous opioids, these are within our own system, we have opioid-like drugs that are constantly circulating around, and the receptors, which are located within the pulp and the periodontal ligament. They just become irritated, and these receptors become inhibited so that our endogenous opioids, right, our natural pain fighting chemistries can help them. And exogenous opioids, which are drugs that we take, sometimes don't help either because these receptors have been inhibited. So at the end game, what do we do at this point? The treatment options, if you've got a full-blown infection, periapical abscess, now you know what that means. Well, you have to get rid of the source of the infection, which is the necrotic pulp, the dead pulp, or the dead nerve. All right. So there's two ways to do that. You can do that by doing root canal therapy, remove the nerve and save the tooth, or if you can't, then you do the tooth extraction, remove the nerve by removing the tooth. So here's an example of a root canal. So we've got our tooth decay and infection, enamel, dentin, caries, pulp, periapical infection. All right. So what the endodontist does, he or she then goes in, makes an entry. Patient's nice and numb, of course. Makes an entry into the pulp chamber, takes instruments, goes down each of the pulp canals, removes the dead pulpal contents, begins to shape the canals and make it aseptic all the way down to the end of the root tip, just inside the periapical foramen. And when it's nice and aseptic and clean, then they pack it with an inert material called gutta percha, which seals it all off. Seal off the tooth, have a crown down on the tooth, happy as could be. You don't have a pulp in there anymore, but at least you still have your tooth. Here's a radiographic depiction of it. Enamel, dentin, caries, pulp, dead nerve, dead pulp. See, I say nerve sometimes still. Periapical infection. Do the root canal, remove all that dead pulpal content, seal off the end of the apex, and it heals. Better example, Dr. Rico Dean Short, one of my mentors out of Atlanta, Georgia. He let me use this slide right here. Here's a really gross periapical infection, right? Even you can read that. Big old dark space down there. So Dr. Short does a masterful root canal down here, just beautiful. Seals off the apex right there and right there. And 6 months later, no more shadow, no more shadow. What's happened? Well, because he's done a beautiful root canal, there's no more exchange of sickly fluids from tooth to bone and bone to tooth. Everything is sealed off. Because now in neutral space, phagocytosis occurs. Certain cells in our bloodstream come in, they gobble up all this dead abscess material, and with 6 months, replace it with normal bone. Now you have a perfectly functioning tooth. Do root canal, you have to isolate the tooth. We're looking straight down onto the tooth before root canal is started. You make your entryway, you can see the pulp canals, and you take your instruments, you go down and you perform root canal treatment. Love this picture, Dr. Lisa Nowlam. She's now a D4, a friend of mine at UCLA, School of Dentistry. And this was a root canal that she did. These are some of the files and cleaning devices we use for cleaning out the pulp canals. And that's actually a pulp right there. Isn't that cool? It looks like a little worm. She was able to extirpate the pulp. You take out the pulp. Oftentimes it doesn't come out in one piece. This one happened to come out in one piece, and she sent me this picture. Very grateful to have that. Or you go to tooth extraction, exodontia. All right, take the tooth out. You take the tooth out. Pulp goes with it. Then phagocytosis and bone fill goes on and heals naturally. Here's my friend, Dr. Daniel Cook-Leahy. He just graduated UCLA School of Dentistry. They sent him back to the state of Michigan for his community-based clinical education. He spent the entire time there just putting sunshine on the roots. Looks a little gross. Get used to it, young doctors. This is what you're going to be doing one day, doing these extractions. Thank goodness for anesthesia, because you can do all this stuff and make it completely painless. There's no reason why any of your patients should ever feel any pain, all right? Local anesthesia was invented by Sigmund Freud and Karl Kohler in 1884. And this is probably a true depiction right here, because they had no anesthesia. Look at this dentist. Oh God, who would want to go to see him? But he was very experienced, and he would hire a dental assistant who would actually hold the patient down because they had no anesthesia. Sometimes they used whiskey, all right, and just would, and look, his hands are tied down, all right, so he can't move because it's all involuntary action, and extracts the tooth. This is a different depiction. I think this was just staged. General anesthesia was introduced by William T. Morton, a dentist in Boston in 1846. A brilliant man, and is now used throughout the medical world because of Dr. Morton. Odontology, or toothache, as described here, you now know as having origin in the dental pulp. But patients will present to you with pain that can come from many origins, and you'll be learning about all this. And the astute clinician will use their knowledge to uncover the cause. It's not always simple. So, my dear young doctors, parting words as we're near the end here. I will say to you, as you go into this profession, there's many ways of looking at the world. And through your mirrors, you're going to be looking at the world upside down and backwards. The end. Go Bruins. Thank you. We're all done. And as Professor Robert Reich would say, what do you think? Let's stop the share and say hello to everybody again. Is anybody sleeping? Anybody fall asleep? No, I think we still have a lot of people here. All right. I would love to entertain any questions or comments. I just want to hear what you have to say. Please come forward. Don't be bashful. There's no stupid questions. What did you not understand? Or what did you understand that you have a further question about? Who here all knows what a DEJ is now? Raise your hand. Dentino-enamel junction. All right. Who all here knows what a periapical foramen is now? Raise your hand. All right. That little hole at the end of the root tip. All right. Good. Good. Who can tell me the pain fibers? No, I'm not going to ask you that one. That's stupid. All right. Questions, please. Anybody? Don't be bashful. Boy, you're all so smart. You understood everything. Well, thank you, everyone. I appreciate your allowing me to come in. I've got a couple of other lectures that I can go back at another time and give you. I'd be happy to do so. And Umberto, I'm going to go ahead and turn it over to you.